Good afternoon, everybody, and thank you for inviting us to share our data with you. To maximize the long-term effectiveness of antiretroviral regimens and ensure sustainability of treatment programs, it is essential to monitor and minimize the further spread of HIV drug resistance. In areas where limited or no routine HIV drug resistance testing is available, nationally representative surveys are recommended to assess levels of acquired and pre-treatment HIV drug resistance. However, uptake of these surveys in countries with high HIV burden has been slow and complex. Subsequent proposals to generate more timely surveillance data include using programmatic viral load data to estimate the consequence of increasing drug resistance levels, or to use laboratory-based sampling of treatment failures. In South Africa, an estimated 7.9 million persons were infected with HIV in 2017. Of these, 4.4 million adults and children were receiving ART through over 4,000 public healthcare facilities across the country. Viral load testing is performed at 6 and 12 months after initiation of therapy and then annually thereafter. National resistance estimates from the country show that in 2014, ADR levels were greater than 90% to the NNRTI drug class, and in 2017, PDR levels were greater than 10%, also to the NNRTI drug class. So we set out to explore the feasibility of using remnant viral load specimens for updated ADR surveillance estimates. This is feasible in South Africa because the country has a strong network of 16 viral load testing laboratories housed within the National Health Laboratory Services. These labs contribute programmatically to viral load testing with a greater than 80% coverage rate across all 9 provinces. Data from the NHLS show that 13% of 3.3 million people who had a viral load test done during 2018 had viral loads greater than 1,000 copies per mil. So our study objective was to conduct nationally representative surveillance of acquired HIV drug resistance in adult patients with unsuppressed viral load using leftover specimens from patients who had undergone routine viral load monitoring. We adopted a two-stage sampling approach. For stage 1, a systematic random sample of remnant viral load test samples was selected over a 5-day period at each of the 16 national viral load testing laboratories. Basic demographic and viral load testing data was collected from the Laboratory Information System database and used to include specimens that were taken from adult patients and that had an unsuppressed viral load. In stage 2, a random sample of unsuppressed viral load tests stratified by viral load laboratory were retained from those in stage 1. So we calculated in order to achieve an effective sample size of 700, we would need to collect 915 specimens from adult patients with viral loads greater than 1,000 per ml. In order to achieve this, we needed to collect 7,485 viral load tests as part of stage 1 sampling. HIV drug level testing was performed using liquid chromatography mass spec and tested for all the drugs available through the public sector program. This data was used as a proxy for current treatment regimen because we did not have access to the treatment history. HIV drug resistance testing was performed using an in-house nested PCR coupled with next generation sequencing, but results were reported at Sanger equivalent. The FASTQ sequences were analyzed using the PAS-seq pipeline. At the end of the survey, we had collected 8,202 viral load specimens, and these were collected between May and July 2019. Of these, 1,052 had a viral load greater than 1,000 and were from adult patients. So from this, we randomly selected 779 specimens for further testing. Drug level testing was successful in all 779 specimens and showed that 56% of specimens tested were positive for ARV analytes. Drug resistance testing was successful in 753 specimens. HIV drug resistance was detected in 72% of specimens tested, with NRTI resistance in 71%, protease inhibitor resistance in 2%, and NRTI resistance in 49%. Resistance levels were significantly higher in specimens that had detectable ART levels, as shown by 87% versus 56%. Resistance was present in 87% of specimens that were from patients that were positive for NNRTI-based regimens, and specimens that were from patients taking a protease inhibitor-based regimen, resistance was present in 82% overall. Notably, resistance to protease inhibitor was present in 32% of this cohort. The most commonly detected mutations were at K103, B106, M184, and K65. In conclusion, 72% of patients with unsuppressed viral load in the public sector harbor resistance to ART. NNRTI resistance was most common, with 71% of specimens harboring resistance to NNRTI, 49% harboring NRTI resistance, and 2% showing PI resistance. Notably, 45% of the patients on ART and presenting for routine viral load testing had undetectable levels of ART. HIV drug resistance was lower in this group, presumably due to lack of drug selection pressure. The survey adopted a novel approach to specimen collection and testing for HIV drug resistance and was successful in obtaining a nationally representative sample. However, demographic and clinical data was not available through the laboratory information system. I would like to acknowledge my contributing investigators in the study, including colleagues from the National Health Laboratory Service, CDC, CDC South Africa, and Boston University. The project was supported by PEPFAR through the US CDC in terms of the cooperative agreement with the National Health Laboratory Service.